Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right, Kane. I mean, like we typically do, we got another good one coming at the audience here. And today, we're going to talk about the PT profession. Not only the PT profession, but where's the profession going? How is it going to be advanced? Is it going to change? Is our scope going to broaden? What are we looking like in 10 to 15 years from now? It's clearly, if people haven't recognized this by now, Kane and I are clearly passionate about this profession. We're passionate about the field. We want it to continue to evolve and advance so we can help more people. So I think we can start by talking generally. What is the current role? And I guess I should preface this by saying we were talking about the advancement of the field of orthopedic physical therapists, neuro, peds, cardio. I don't know anything about that. So let's talk ortho. So what do ortho PTs, what's their role currently? Where do we fit in? When I think of that question, I just think, okay, keep it simple. Generally, we are evaluating, we are treating people with musculoskeletal pain. Plain and simple. How are we treating these patients? We're using movement and exercise to reduce their pain, improve function, and help individuals achieve their individual goals, right? So I don't think that general definition or that general kind of identity of the orthopedic physical therapist has really changed much. I think what has evolved and what has changed in the last, let's say, between 10 to 20 years is the amount of autonomy we have. So that has come with the expansion of direct access. We have direct access is unrestricted in 21 states, and in 29 states we have some restrictions. And those restrictions come in the form of, you can only see someone without a script for a certain amount of days, stuff like that. So with direct access, again, we're able to see patients. We're first-line providers. I think that has been a positive advancement in the field of PT. Now, when we talked about scripts, we talked about referrals. Another way I think PT has changed is like, hey, maybe like 15, 20 years ago, you'd get a script come in, you'd have specific orders from the referring provider, right? Maybe it'd say, hey, you see them for this many times a week, for this many weeks, and you do these kind of exercises, you do these modalities, this is what they get, right? Now, more often than not, the referral is plain and simple. It has a diagnosis attached, and it just says evaluate and treat. So to me, that's telling. To me, that's like, hey, this referring provider is saying, hey, this is what I think's going on, but I know this is your wheelhouse. This is up to you as a PT. You do your own thing. This script just serves as something that says the person's allowed to come to your clinic, evaluate, treat them, send me the plan of care. I'll sign it. No questions asked. So again, I think comparatively, if we're looking back 15, 20 years, we're getting essentially what were demands, instructions, what to do. Now it's just saying, hey, here, this person has pain. This is, evaluate them, treat them if you think it's appropriate, and go from there. Kane, where do you think, just speaking generally, like, what's the purpose? What are we doing as orthopedic PTs right now? How have you seen, maybe comparing in the past, how the field's advanced?
Yeah, I definitely think that there are aspects that the field has advanced in, right? Like growing up, I did not want to be a PT. I actually despised a lot of what PTs did because it was pretty much like a conveyor belt. You came in, you got your heat and stim, you got your band exercises, you got your ice, you were shipped off back home with an HEP that everyone got. To me, that's not deliberate care, right? And that to me is also essentially standardized care, right? And that's something that I think still goes on to this day. But for the most part, we have started to move away from that. And I think that is so, so helpful. We are finally starting to adopt and earn the title of our doctoring profession. I think that's huge. That is so awesome to see. That is the reason why I joined PT. Now, I'm sure that's probably the reason why you joined it as well, too, is because you want to help people and you want to do so in this
Yeah,
particular
I want to
avenue.
do my own thing. Yes.
Yeah. I think that that is a huge step where we are starting to receive more autonomy, right? I think that the diagnosis that the doc gives and then the eval and treat, awesome. Let me do my job. Fantastic, right? We get to function in our own expertise and then we get to work with each other in that manner and in that capacity. I think that that is so helpful. The aspect of direct access, I think, is a huge component that was severely missed on. I think it is so crazy that we have had direct access or DA for like so many years. And I have so many patients that are like, oh, we can come see you without a script.
Mm-hmm.
Wow, guys, really nice job on advertising and marketing that
really
for our field and profession. Yeah, that's fantastic.
Yeah, because a lot of people, a lot of patients know, they're like, or the patients who utilize direct access, they get it. They're like, hey, why am I going to my doctor? Why am I even going to ortho when they're just going to send me here? Right? It's like, let's cut out the middleman. Come to PT. Come to the place where the magic happens, where the patient's getting results, right? And then, right, if maybe those results, the magic doesn't happen, and we're not getting results, hey, then you go back to your PCP. Then we send you back to ortho, right? You kind of flip the script there. And the patients who are utilizing direct access, which at least the clinic I'm at, it seems to be maybe around like 20% of patients. I mean, they see the benefits, come in, get something taken care of, and then they're good. Then you're cutting out an extra step. You don't have to see PCP, you don't have to see ortho, you don't have to waste your time, you don't have to waste your money, straight to PT. But I agree with you. I think the amount of people who are surprised or just they don't have any idea of the existence of direct access, then they just think it's like the old model where it's like, hey, I gotta go to the doctor first and they send me here, right? It's surprising to me that more people still don't know about it.
So I think that that is such a huge component too, because the fact that some patients recognize this, it actually really enhances the therapeutic alliance that you have with that patient. Like, Mark, I'm sure you could attest to this. When a patient comes in and their DA versus like a standard patient that had a doctor script, those patients have already bought in. They already
took the words out of my mouth. Exactly. They've clearly trust and respect physical therapy as a profession if they are identifying like, hey, this is where I need to go to get help. And they've gone and made the appointment without, doing the typical route.
Yeah, they already have buy-in. They already want to do the things that you're going to tell them. There's a good chance that you have a good relationship with them, or they've heard of you and you have a good reputation, right? So all those things are just playing in your favor. But the biggest thing in my opinion is when someone comes in with a DA, it's just like what Mark said, they respect the profession. They are not just coming to you because the doctor told them to, or I need to come see you so that I can get authorization for my surgery or injection or whatever it is. They're coming in because they want to get better. They want you to help them. That is huge. I can't stress that enough. I think that the patients that come in because of that helps our profession tremendously. The fact that we haven't continued to push this, like the knowledge that we could be seeing direct access, is beyond me, right? I'm not advocating for like a further advancement of direct access by any means, right? But the fact that it exists and people are not well informed about it is just such a disappointment, in my opinion, because these are the people you want on your side. This is how you could really start to change the profession, in my opinion, or at least one of the ways, right?
Yeah, I think it's an easy route. It's an easy avenue. I mean, the legislation, the laws already exist. Like, why don't we get the word out, facilitate this, get more people into PT, right? And without having the extra steps, get people to PT, they have a good experience, and you just have that that chain reaction, that positive effect. So Kane, we talked a little bit about where ortho-PT is now. We talked about how we've gained some autonomy in the past, 10, 15, 20 years. We talked about how a lot of that has come through direct access. Going forward, where do you see PT going? Where do you see the proposed role of orthopedic physical therapists going, let's say, in the next 5, 10, 15 years? Some things that, perhaps we could focus on, some topics. Where do you see it going?
Oh man, this is a huge soapbox of mine for sure. And as you can tell with my perspective of direct access, I think we should be the first contact, like the primary point person for people when it comes to musculoskeletal pain. Like, short and simple, we're going to list out a couple reasons as to why and how this impacts our healthcare system. But this is like the profession to do it, because we have the ability to evaluate. We have the ability to then treat conservatively. We then have the ability to refer to the appropriate source when it's necessary, right? We actually get time to spend with our patients. And that is so, so important. We are not doing a quick screen to just make sure that everything's all A-okay, that nothing's going to fall apart on them, right? We are actually diving in, like we're going to screen them for the big things, the red flags, all these different things. But we're also going to be able to create a solid working hypothesis. We're going to be able to identify the relevant deficits, and we're going to be able to work through that and see if there's actually any change, right? So the ability to evaluate and determine how safe a patient is, and then how appropriate PT is for them. I think that is like such a huge cornerstone. It is what we do. So why not expand on that and actually make that like our job? Because we're already doing that. Just put us in that position to continue facilitating that even further. Now, this also ties back to the last thing, the last point that I mentioned, which was the fact that we're a doctoring profession. I don't want us to be a field where we just give cookie cutter exercises or protocols to patients. That is like, we have moved well beyond that. We can do so much better. And pretty much like what Mark and I have talked about throughout the entirety of this podcast is we can do better. You can always work on identifying things more specifically, applying interventions with more intentionality, providing justification for all of the above, right? When we do these things, we are actually elevating our standard of care. And that is the biggest thing that I hope that we could get across to the future generations of PTs. Now, with all of that being said, I think that we also could have additional privileges. Some of these we've already kind of touched on, where some PTs are able to do so, others not so much, right? So the first thing that I think that we should be able to do is order imaging. My God, physicians utilize imaging like it's candy. Every single thing, X-ray, MRI, CT scan, done. It's just like, what happened to the whole point of this being like us saving money for insurance for the patient? For like, it is seriously just a huge way to generate waste, because a lot of times, as we know as PTs, the imaging doesn't matter a whole lot until it does, right? But for the most part, it's like when it doesn't matter, it's like it doesn't matter.
Yeah. And the surprising part to me about this, and I agree with you, like I think we are, as PTs, we are in such a unique, such an appropriate position to be able to have additional privileges, additional the responsibilities when it comes, such as like ordering imaging. We're in a perfect spot for it. We get a good amount of time with patients. We're able to fully assess them, like you said. And then listen, it's not like we have our own guidelines as PTs for imaging. We share the same ones that everyone else does. We have the American College of Radiology guidelines. It is broken down by any kind of demographic, any kind of characteristic, any kind of clinical presentation you want. You can get up-to-date research-backed specific guidelines for imaging. So it's simple. Like, we can follow them, but like you said, like, they're clearly not followed when we look at how overutilized imaging is in primary care offices, in the emergency room, in other specialty offices such as like orthopedic stuff like that. So again, like as PTs, like we're orthopedic PTs, we're assessing movement. We have this background knowledge. We get classes in school about imaging. I don't see why not, as this, especially as in order to advance the profession as we expand, being able to order imaging. I think it's perfectly appropriate for PTs. And again, I think it's a maybe not. I think it's a necessary step going forward to advance PT.
Yeah, and the other thing is that I think about is when it comes to ordering imaging, right? This example just jumps straight into my head is someone who sprained their ankle and they go to the care now. What do they immediately do? They immediately order an x-ray, toss them in a cam boot, and give them crutches, right? Like that is like the typical presentation that I see that walks through my door when someone has a sprained ankle and they went to a care now instead of just holding off and then coming in to see us, right? Essentially, they don't apply the Ottawa ankle rules to help reduce the cost of that. We already know statistically how much it helps mitigate the cost of imaging, right? Like that to me is so crazy that we have this like very, very highly backed like cluster that teaches us like, hey, they don't really need this. And I know I bashed clusters before, but this is such a straightforward one with such a high statistical relevance that tells us like, hey, we could probably avoid this. We don't need to do this, but they still do it anyways. They just completely ignore it, right? So I think that is probably one of the biggest things that pops up into my head. Like, we could skip this. We just let us do our job. We can treat this. We can order imaging when it's deemed appropriate, right? I think that for a lot of basic stuff, most PTs should be able to do that. Maybe for MRIs, you could have like further credentialing or something else. If you're taking a look at like a spine, for example, I think that's totally fine. But for most basic cases, I think that is a privilege that should be allowed.
Yeah.
Now,
and I think it's just to add on to that, like you talked about maybe MRI for spine, stuff like that, like in the case where maybe they're not responding to PT treatment, maybe that's a little bit, maybe that requires further training or education or certification, stuff like that. But when it comes to someone comes in and you talk to Ottawa ankle rules, ankle sprain, or like let's say we're suspecting like a stress fracture, or like you said, like maybe an avulsion fracture with an ankle sprain or something like that. It's like, red flag type stuff is popping up to us. It meets the guidelines that we're following. Hey, we should be able to order at least plain films, X-ray, get it screened out so we know nothing bad's going on.
Yeah, like can you imagine if if you had something like that in your clinic, like we're actually responsible for doing that, and then now we can just like see that in real time and interpret something like that like super fast. That would be massive. You just figure out what the problem is so quickly, and whether or not if it's a necessary tool, right?
Yeah, and I think pairing an imaging right with what we already have with direct access, I think they just go hand in hand, right? Again, it's a little bit I think it'd take a little bit to get there, but if we're going to be first contact providers, having something such as imaging rights, I think is necessary.
Now that actually ties in super well. So like being able to order imaging, having DA. Now the next one is the ability to place referrals, right? What happens if they do have that avulsion fracture? What happens if you do catch something that's red flaggy or something that's non-responsive? We should be able to place referrals for a patient to have expedited care, essentially, to a specialist. I think that is huge because now we are serving our purpose as the point person. We're doing our job. We are delegating care where it needs to be sent. We are triaging our patients appropriately. That is such a huge component of what we already do. Let's just make our job faster and easier. Like I can't think, or I can think of so many patients where they're like, oh my God, I am dying. I can't get in to see anyone for another like 3 weeks, 4 weeks, right? For something that's like spine related. I'm like, oh my God. Like, I wish that there was something else I could do. Right? Like you already made the referral and it takes that long. That is just so crazy to me. Like, and it's not like these places don't have openings. Like they certainly can, or if someone cancels, they can certainly reach out. But this is something where I'm like, hey, there should be a list essentially where it's like, hey, like this is a serious problem. We need to get them in now. Right. Yeah, I think that's so important. Like, they need surgery. Like it should be like, boom, like we're moving.
Right. So like again, like us as PTs, let's use spine as an example. Like someone comes in, they got a hot, nasty ridic, right? Myotomal weakness, sensation loss, just nothing good. Not looking, or let's say, and these are progressive neurological deficits. We've seen them for the eval, one follow-up because they can't get in anywhere else. I like the point you made. What if we were able to place a referral and the referral went in? Okay, this is a physical therapist recommending this. They're recommending the patient be seen as soon as possible because they have the following deficits, right? It's like, okay, cool. So we have justification with a PT referral. Maybe that gets expedited a little quicker compared to maybe someone who's had neck pain for like 6 years, right? It's like that person can wait another week if we can get this person in that has this these acute progressive symptoms, and again, PT symptom, they have good justification.
Yeah, and the other thing is, let's just use that example that you just brought up, right? Let's say that someone has a super nasty ridic, and we evaluate them. Most of the times, we are not just going to be, oh my God, this is awful, let's send you. Right? Like we didn't even take a look. Let's take a look. Yeah. Let's see what's going on. Right? Like how many times, Mark, have you seen something that's like, where you're like, oh my God, this is terrible. And then you have them bend backwards a couple of times. Like, oh my God, this feels so much better. Right? I can think of very clear cut cases that were like that. And I'm like, yes, I knew we could do something about this. Right? Instead of just like panicking and shipping them off right away. I think that is allowing us to do our job, trusting us to have that autonomy to do a good job, not just our bare minimum, but doing a good job and making the right referrals when needed. Right? That is probably such a huge thing that I'm sure patients would really, really appreciate, because, and I'm sure physicians would also appreciate, because they're like, oh my God, how did this end up on my doorstep?
Yeah, right. and this is another, I think, part like when we can also has similarities to imaging is like, I think some referrals are overutilized as well. Like someone goes to their PCP and they just have, I got back pain, I got shoulder pain. All right, you're going to see ortho, you get to see sports med, you got to see PT. It's like there should be a system to this. There should be a method. There shouldn't just be have blanket referrals placed just because it may be appropriate. You should have reasoning. You should have good justification. I think as PTs, like I said, we have more training in the musculoskeletal orthopedic assessment. I think we would certainly have good justification and reasoning for placing referrals if we had the right to do so.
Now, I think this also ties into the next one. It's funny how all these really, really go hand in hand, right? So if we're limiting how much imaging we're utilizing, we're limiting how many referrals that we're having to send out, because that's just based off of our training, right? Like we are trained to be more conservative in our care. And I think it's funny that I say conservative while I just straight crank patients to their end range, but it's conservative, meaning they don't need surgery. They may not need medication or whatever. We are pretty much like cost prevention for insurances and for patients, right? That ties into, I think that PTs, and this isn't for everyone, But I think that if you have credentialing for this, you should be allowed to prescribe medication on a limited basis. If someone has an acute flare up, could they use a dose of prednisone or gabapentin or NSAID instead of needing to wait and go see the doc for them to be prescribed? Or they're prescribed this before they see us and they're like, that did absolutely nothing. I don't know why I took that in the first place. And so it's stuff like that where I'm like, hey, just let us take a look, see what's going on. If things change, awesome. We don't have to go down that route. If things don't change, hey, we have a couple of other avenues that we can exhaust first. Let's try X, Y, and Z. See if that helps, because these are the common things that docs are prescribing anyways, right?
Yeah.
So if they respond to that, awesome. Good. We found something to calm it down and we're using it prudently. If they're not responding, boom, then we could send them for imaging, send them for referral to the appropriate source, whatever it is. But we've kind of gone through that decision-making tree already. They don't have to do that anymore. We are taking on more responsibility for these other professions, for them to not have to do that anymore. They can open up and do a lot more with their time and with their resources. I think that is so huge. We are essentially cutting down on so much wasted time and resources for both the patients and the physician as well too. I can only imagine how many more people that they'd be able to see and help, like actually help with us taking on that caseload, right?
Offloading it a little bit. Yeah, exactly. And I mean, I don't know if you have any specific, like we talked about, limited prescription of certain medications. Like what comes to mind when I think most appropriately for orthopedic type pain, what I see prescribed most commonly by PCPs anyway, is something like a prednisone taper, maybe a gabapentin if they have radicular type symptoms, so a higher dose NSAID, stuff like that. So it's not like we are looking to, I mean, I don't know if you have anything to add in that regard, any other medications, but in my mind, like just a couple like that, just something to, if someone has some acute pain or an acute flare-up of chronic symptoms, like just something, if they're not responding to movement and but we don't feel like they need imaging currently, they can still be treated. They just need something to help things calm down so they can move a little bit better. Again, like a lot of this stuff's getting prescribed by PCPs anyway, and it's maybe overutilized in some cases. Again, I see it as like a blanket prescription. You have pain here, we're going to give you 600 milligram naproxen or gabapentin, prednisone, this, maybe a muscle relaxer as well. And in a lot of cases, there's not much of a response, but there's no follow up with that, right? Just like, oh, here's your 30-day supply of gabapentin, and you just take it, how it's prescribed, and you follow up with your PCP. Never. Yeah, it's like, what if we were able to give it to them? Hey, this should, yeah, right, exactly. Like, this should help within a couple days. If it doesn't, like, you probably don't have to take it, right? Like, there's not really a point to. So again, another aspect of care, which us as physical therapists, we're in a unique position in that we're seeing people more frequently than a PCP seeing them, than another physician provider is seeing them, and we are able to look over their care maybe a little bit better because we are in this position to see them a bit more frequently.
Absolutely. Absolutely. I couldn't agree more. Right. And with that being said, I do think that with these increased privileges, that means that we're going to have to take on more responsibilities, right? We're going to have to do more things. So, Mark, can you tell us a little bit more about what some of those responsibilities might entail and what we should really expect for PTs to be able to take on this new role?
Mm-hmm. Yeah. So I think we would be ignorant to think that we could just possibly get all these increased powers, privileges, responsibilities, and with that increased autonomy without having to maybe fine tune our evaluative processes. So I think the first and foremost, if we're going to advance PT, if we're going to be by being first contact providers, we need to be good and we need to be specific about gathering relevant information. When I say relevant information, I mean things such as past medical history, things such as medications. We certainly have to be good about red flag screening. So a couple examples that we already provided, like such as Kane talked about an acute ankle sprain. We could screen using Ottawa ankle rules, right? If we find they're positive, we could refer for an x-ray. If we're going to be first contact providers, we need to be able to pick up on those things. Let's say, for an example, someone comes in with an ankle sprain and we just, do our PT thing and we don't give a referral. When we treat them for a month and let's say they get worse and there was an underlying fracture and then they ended up needing surgery and we delayed surgery and then there's a chance of non-union, stuff like that, right? So if we want to make a case for PTs being first contact providers, we need to make sure we're good at those things. We talked about we talked about medications. Now, I don't think it's possible to know every single medication interaction that exists, clearly, but we may need some more knowledge or about how common medications that someone would be on for different conditions and maybe how they interact with the certain medications that we may be able to prescribe, right? Now, I know there's programs, I know there's even things built into EMRs that will flag certain medication interactions, but I mean, I'm sure there's certain ones that can be overridden and maybe common interactions that get overlooked, right? So I think if we have some more information, some more knowledge in that regard, that will build our case for being able to prescribe medications. Again, I want to emphasize that we need to be good about gathering past medical history. If we want to be first contact providers, we need to get the entire picture of the patient, not just what they're coming in for from an orthopedic standpoint, but we need their past medical history. We need current medications if we're thinking about prescribed medications, and we need to be good about screening for red flags and knowing the appropriateness of placing referrals or sending for imaging based on red flag screening, so we're not continuing to contribute to the problem that we're trying to address, which is overutilization of referrals, medications, and imaging.
Yeah, I think that all of these things are just so important to have because like these are some of the things that we were trained to do in school, right? But yeah. I think that it's just like it's almost like we're not necessarily being, I don't want to say trusted with this ability to do so, but it's almost like it's almost as if they want to give more like checks and balances where it may not necessarily be needed. Yeah. I really think that we could make such a bigger change and be a way more efficient like machine when it comes to the healthcare system. Yeah, we should be able to.
Yeah.
Go ahead.
Yeah. I mean, sorry, I can't help myself. We have, where I work, there's internal data and there's also public data from other health systems where, like, when PTs are put in a position to be able to, and this is mainly from spine, when PTs are able to screen patients and determine if they can be treated with PT, if they need to be referred, or if they need imaging, medication, like there is an extremely low chance of something being missed or any kind of like adverse effect, lower than that if they were to just to see their PCP or go to the ER. And more importantly, there with the lower risk of adverse events, actually like imaging and medication, the utilization rate was much lower, right? So it's like a win-win, right? Imaging's being utilized less. It's only being used in case when it's appropriate. People aren't being overprescribed medications when it's not appropriate, and things aren't getting missed. There aren't an increased risk of adverse events occurring when less imaging and less medication is used, right? So it's like, why isn't this kind of system being utilized more broadly?
Oh, like that is such a huge discussion point, right? And that really does just hit on the purpose of why we want to advance the profession in this manner, and that a lot of it is to reduce unnecessary medical visits. A lot of it is to help bring patients faster and more effective care. Who wants to be in pain for longer than they need to be, right? So if we're able to give them the intervention that they need why are we still having that referral system? We can actually do this more efficiently than, say, like a PCP or potentially a sports med or ortho, just because of our training as well as the resources that we're given. We have more time, right? We have more time, and we're able to investigate these things way, way, way more thoroughly compared to some of the other like physician counterparts, right?
So where do these physician counterparts fit in, right? We've talked about how I think our proposed role as first care providers, physical therapists, where we fit in. We're in a good position. We have more time. We see patients more frequently. Clearly, there's a role for our physician counterparts. And what do you think the proposed roles are for those counterparts?
Yeah, so I think that for PCPs, I actually think it's kind of funny. I think that the PCPs probably have the best referrals because they know what they don't know. They fully acknowledge this. They're like, listen, I took like a couple classes in ortho, and that's all I got. We're good. This is your wheelhouse. They just ship them our way, and they're like, hey, I can't figure this. I don't know what this is. You probably do. Please help, right? So I think that though PCPs are fantastic, they actually do such a good job with it. A lot of times they don't overly prescribe things either. They may give them like something that's like more conservative in the pharmaceutical realm. I actually have a PCP who is not giving any like pharmaceutical intervention until the patient has been seen by PT, which I think is kind of crazy. That is the first time I've seen it, and I'm like, you know what? I kind of respect it. That's the first time that I've actually seen that. And so when the patient comes in, they're all grumpy and stuff, but if I can change their symptoms, I'm like, hey, listen, that just means that the doc did a good job. He did his job. He didn't think that it was like something that would be rectified with medication. And so he sent you over to us, and look at what happened. You're feeling better, right? So I think that is a win-win-win for everyone, right? It makes them look like they know what they're looking at. It makes us look like, oh, we understood the problem, we fixed it, and the patient doesn't have to take unnecessary cost and medication, right? Like I don't know about you, but I see so many patients who are like, I hate taking medication when I don't need to. And I frankly feel the same way.
Yeah, but I think, yeah, exactly. I agree with that. But their condition within the current medical system, or the experience they've had with it, it's like, oh, I was prescribed this. The doctor told me to take it, so I'm going to take it. I mean, I can't. The amount of patients that will discuss, like, hey, they gave me this medicine, it doesn't really do anything. Should I still take it? And it's like, listen, it's not within my scope. I can't tell you how or what medications to take, but if we're going to speak generally, the purpose of this medication is to help with your pain. If it's not helping I don't.
Probably don't take it.
Why would you take it? Right. all it does is make me sleep, and then I can't drive on it. It makes me dizzy sometimes. I have to use the bathroom a lot, but it does nothing for the symptoms I'm supposed to be taking it for. It's like, hey, maybe you shouldn't take it, right?
The next physician that we have on our list is the orthopedist, right? Orthopedic surgeons, more specifically. These surgeons should be reserved for what's their title? A surgeon? Surgical consults. Yeah. Oh my God, that's crazy, right? These patients should come see us, and then after that, we're like, hey, things don't seem right. I think that you probably need something else, right? I think that you probably need surgery. Let's see if maybe it's a torn rotator cuff. Maybe you need a repair, or maybe you're completely functional without a repair, right? Or maybe they are an ACL rupture, and we see them and we're like, hey, you're going to continue playing sports that are like high risk sports. Let's talk to the ortho and see what's going on, if you should get a surgery. Or, oh, you're 40, 50 years old and you don't intend on doing anything rigorous and you're a coper. Let's stay away from that surgery. I don't think that you're going to want to go through the rehab. That's totally fine. You're functioning absolutely perfectly. You're able to do all the things that you want to do. right? So it allows us to actually contact our patients in a completely different perspective. Like we're actually able to have those conversations without initial biases. And I think that this is such an empowering thing for PTs, because now we're actually changing the public perception. Now it's not just, oh, this is wrong, I need to go see the doctor. But now it's, oh, this is wrong. Let's see what both sides of the coin have to say, right? Like, let's see what it's like being treated conservatively versus surgically. And you can always trial a conservative option and then seek out surgery. You cannot undo surgery. So yep. I think that is a huge thing for patients, because I've had quite a few people where they end up getting surgery and they're like, I kind of regret it. I'm like, yeah.
I mean, like you said, there's two sides of the coin, right? So you see someone who their title is surgeon, they will specialize in surgery. They will do surgery if they find anything, right? And I think unfortunately there's a lack. They get imaging findings, they see a tear, whatever it is. Oh yeah, that needs to be repaired. Unfortunately, there seems to be a lack of clinical correlation in those scenarios, right? And whether that's due to the lack of time the surgeon has with the patient, maybe, I don't know, if the surgeon just, has tunnel vision on the imaging, whatever it may be, we as PTs, we have more time with the patient. We're able to track their progress over time. If they wish to pursue conservative treatment, we're able to interpret the imaging findings from the impression of the radiologist and or the orthopedic surgeon if they've gone there. We are able to draw any kind of clinical relevancy with our evaluation, and then we are able to take all that information, discuss with the patient with the time we have, get their thoughts, provide our input, and then develop a plan with them going forward.
Yeah, and this also is something that ties into the other specialty as well too. My personal favorite, trying not to show my bias here, sports med, man. So I think that this is where we can utilize them more appropriately than how they're currently being utilized, in my opinion. I think that I think they are supposed to be the primary contact for orthopedic conditions that are non-spine for the most part, right? Usually that's reserved for pain and spine physicians, but these guys are usually responsible for most musculoskeletal conditions that are non-surgical. They are also usually the ones who are directing patients to PT or to surgeons if needed, and they're also giving them pharmaceutical interventions, or they're managing their medication as well too via injections, NSAIDs, steroids, any of that other stuff, right? And this is where I think why is the primary contact person the person who is issuing non-conservative treatment. Mm-hmm. Why is that the first line of defense? Why isn't it the opposite, where we are treating them conservatively, seeing whether or not they need pharmaceutical intervention, and then going on from there? That seems like the most rational thing that we could be doing. But lo and behold, that is not the case. So I think that sports med could certainly be utilized better. But I mean, at the same time, this is where part of me wonders where PTs can almost essentially function in a very, very similar manner. And I think that we can do a pretty gosh darn good job of it as well, where we are able to thoroughly assess and evaluate our patients, understand when there's a need for imaging, understanding when there is a need for medication, or if there's just a positive response to an intervention, right? Like we're actually investigating this versus physicians are unable to do so with their constraints on time. I think that is just such a huge thing. So that is like, one of my big things is like utilizing PT's new role as the sports med role, and then being able to assume some more of those responsibilities to help lighten the burden that they're having to see a lot of these patients for. Now, the next two, I did mention the one, which is pain and spine. I think that these people are very, very helpful. They also administer pharmaceutical interventions as well as perform medical management for people who have spinal conditions, right? And that could be either the ones that I usually see are going to be like traditional medical management of their medications, usually gabapentin or a muscle relaxer or a steroid, whatever it is. They're usually going to order imaging, and then they are going to give an epidural, or they're going to give a trigger point injection, right? I think that these can be helpful interventions. But once again, I think that this is where patients would really benefit from seeing us as the primary source, because now we're actually referring them when we think that they need imaging, when we think that they need some sort of other intervention. And it drives me nuts when I make that referral to a pain and spine doc and they have to sit through the consult, and then they have to wait another week or two for imaging, and then they need to wait for that to be interpreted, and then they need to wait to be booked for an epidural, which I would have told them right from the start, hey, this is not responsive. We should expedite this. Right. Like, I think that that is such a powerful thing that we can do and help each other like that I can only see positives when it comes to that relationship with pain and spine docs. Now, the last one is neurosurge, right? Once again, this fits right in with that title of they are surgical candidates. These are patients that typically are going to have progressive neurological deficits resulting from like a spinal condition, right? So these are the patients that we're screening for red flags, and we're like, hey, this does not look good. I need you to go in and be seen by a neurosurgeon to see if they potentially are a candidate, right? I think that this is another healthy way of utilizing this resource, instead of having neurosurgeons refer their patients to us, where I don't know about you, Mark, I've seen a handful of neurosurge patients, and I'm like, this is not orthopedic. I don't know what you just gave me, but there is no way that this person with all these red flags is orthopedic. Please take them back. It does not usually bode well from what I've seen.
I mean, the ones I've seen, I don't even know how they ended up at a neurosurgery to begin with. Like, some of these people that get referred there, and I'm just like, why is this the first person you're seeing? You're getting a surgical consult for this pain that you've had for 2 weeks, and your PCP referred you there because you have neck pain and you also have arm pain. It's just the triaging like process is completely gone. It doesn't make any sense. But rarely do I get referrals from neurosurgery from people who haven't already had surgery. But when I do, it's typically not appropriate, right?
Yeah, I think it's also so funny because I've rounded with a few like ortho spine surgeons as well as neurosurgeons, and so many of their patients, they're just like, you're not a surgical candidate, and walk out the room. That's it. That's all that they do. They literally screen them. They're like, nope, not a surgical candidate. I'm out. And that I actually respect that. They are turning down unethical money to prevent patients from getting unnecessary surgery, which in my opinion, and in the hospital network that I work for, I think that that's awesome. There are a lot of other hospitals that do not do that, and that to me is like mind-boggling that is acceptable or like remotely appropriate. But somehow these patients end up on their doorstep, and these docs always are like, how did they get here? And they get so annoyed when they see like 3 or 4 non-surgical patients back to back to back to back. There's like, what am I doing with my day? I am a surgeon. I am here to fix your problem. You are not presenting me with a problem that I can fix. You should go to someone who can fix it. And then they usually just stare at me and they're like, go see him. It's as simple as that, right? So just make us that point person. Boom. So many people's lives would be that much simpler, right?
Yeah, exactly. So it's like, I think the general gist we're getting at here is like, hey, so there needs to be a better process or for referrals to be placed, right? Like people are getting referred to different specialties, different providers, and it's just not appropriate, right? Or they are not the appropriate first provider to be seen. So what we're proposing is like, hey, PTs, we have a wide skill set. We get a good amount of time with patients. We are able to evaluate them thoroughly, get the right information. We are able to place appropriate referrals when the referral is necessary. Now, with, again, like we talked before, if we're going to have this responsibility and autonomy, we need to, there's going to be, maybe some bumps in the road. So, first and foremost, if we were going to do this, we need to make sure that there's some kind of quality of control, right? And like, let's be honest, like there's maybe most of the current orthopedic PTs may not be equipped with the knowledge or skill set to be able to handle a role such as, being a first point of contact PT, as we've proposed and described previously in this episode, right? So there's multiple avenues I think we could go in order to ensure that quality. I know the APTA, or I guess the American Board of Physical Therapy Specialties, is releasing a primary care PT specialty coming up. I think the first exams are in 2028 or 2029, but regardless, that could be a possible avenue to vet people so they have sufficient knowledge and competency to be able to assume that role. Now, I think an issue with that is that, listen, we already have a bunch of specialties. We got orthopedics, peds, neuro, geriatrics, whatever. And not a single other medical provider knows what any of that means, right? They see OCS, GCS, SCS. It's like, okay, cool. You got more letters by your name. It doesn't mean that you're going to get more referrals. Doesn't mean you're going to get more patients. It doesn't really do too much. So I think maybe a specialty certification to be a first contact provider as a physical therapist, maybe it would be worth something, but I think that's, I don't know if it's going to get us too much. So regardless, some kind of quality control I think is probably necessary in order so that we can say, hey, people are doing this. As PTs, we can handle it, and we have data to support that, hey, we are reducing unnecessary medications, reducing overutilization of imaging, and we are placing referrals more appropriately. But in order to say that we are doing that, I think we need to start on maybe a smaller scale, limited to a certain amount of providers that, have knowledge or experience in this, and then begin to expand as we have more data. I think that's a way that we can get a little bit more recognition within the medical field, within hospital systems, from insurance companies, to show them, say, hey, as PTs, we're able to enhance the patient experience, reduce healthcare costs, and we're able to handle this. That being said, how do we start to gain that knowledge, right? So we get some kind of knowledge. We have classes in school about pharmacology, medications, red flag screening, imaging, things like that. But is it enough to say that, hey, we have this knowledge, this is what we're taught in school, this is enough that PTs can be a first contact provider for orthopedic issues? I think it's a good starting point. I think it could probably be built upon, right? Like I think, like we talked about before, knowing more about medication interactions, knowing more specifically about guidelines for referring for imaging when it comes to all different body parts, so that we have all of that knowledge, we can put it together, and we can have sound reasoning and justification for imaging, for medication prescribing, for referrals, right? Again, we need to be able to build our case so we can show that we are capable of assuming this role and enhancing patient experience.
I was just gonna say, I think like the big thing that I'm seeing for like the quality assurance is like this is like why one of the reasons why we want to continue elevating that's our standard of care, right? I think like the big thing is when PTs have these gaps in knowledge, right? We're already trying to elevate the standard of care. We're now trying to push and expand on our scope and gain more privileges. This is where I think that if we want to move the profession in the right direction, we need to step up our game. We need to improve on our standard of care. We need to improve on our gaps in knowledge. And listen, there are already like gaps that we talked about, right? There's like pharmacology, there's like red flag screening, there's imaging and interpretation of that, knowing when someone may need a surgical consult or other pharmaceutical intervention or anything like that. But listen, we still have gaps in knowledge when it comes to musculoskeletal issues and how to evaluate and treat it. And it differs across the board, right? Like we're already discussing how to investigate like spinal pathology. These are things that really should be hit.
Yeah, like if we don't even have our if we don't even have our baseline knowledge down on what people think physical therapists do and are able to do, like it's kind of hard to make the case that we can start to expand our scope, right? So even building that foundation, having a solid framework, having a solid system to be able to do what the public and what other providers perceive physical therapists to do, which is treat people with orthopedic related musculoskeletal pain. How are we going to make the cases that, hey, we also want to be able to prescribe medication, order imaging, and place referrals? Again, it's a hard sell. I think we can start to gather that data and we can start to build a case. But if we want to do it on a larger scale, then we're going to have to make sure that we have our foundation built. So what's the solution? I mentioned earlier, certifications, competencies, classes, something to say that you've had the sufficient knowledge and information to be able to be or assume the role as a first contract provider as a physical therapist. Again, I think it's a start. I think it can be okay. The problem with that is that these competencies and certifications are typically only recognized within the PT field, right? So if we would have to be able to prove essentially to people, legislators, lawmakers, stuff like that, that, hey, if someone passes competency, the people who have passed it have been able to place imaging, referrals, prescribe medications in a safe and effective manner that is in line with the current recommendations or standards of the healthcare system, right? So I think if we would approach it in that regard, in that manner, it could be effective. But if we just have something that says, hey, you're a specialist in primary care PT or first contact PT, whatever you want to call it, I don't know if that would be enough to be able to have more people do it, right? So I think a competency, a test, a certification, course, whatever it is, I think it can be effective, but I think the manner in which we approach it and demonstrate the competency to the general medical field, I think we need to be a bit more finite and specific about that so we're able to expand our scope. Another option would be to include this kind of material in school. So let's say, we're a couple years down the line, scope's expanding, we have a small, a certain percentage of PTs who have demonstrated competency through coursework, whatever it is, and have become first contact PTs. Maybe if we want to start to implement on a larger scale, we could change the structure of the coursework in school. So incorporating more, whatever it is, pharmacology, imaging, referral, red flag screening, all the kind of stuff that would be included in the certification or course, or a certification or a course that would be for first care or primary care PT or first contact PT. Work it in the school, right? So if we start to expand that scope, we've demonstrated we can do it on a small scale. Hey, maybe we could start to incorporate it on a large scale. If we find that the knowledge is sufficient in school and we have data and we find that on a larger scale, PTs are able to demonstrate competency in the fields such as ordering imaging, placing referrals, and prescribing certain medications, then we really start to build the case. We can gather more data, and we can really start to open it up for new PTs and current PTs. Now, Kane, we may be asking a lot here, right? We may be working into other scopes of practice, starting to invade the other providers, right? Like, we're essentially trying to assume the role of what we think we can do better than that of, PCPs, ortho sports med, while also working with those same professionals just in a more effective and more efficient manner. So why don't you tell us like how that would fit into the current medical model?
Yeah, so we're stepping on a couple of toes here, right? And I think that if that's the way that you would like to view it, then so be it. But I will say that for the other medical providers that we listed previously, we're not really stepping on their toes. We're kind of making their jobs easier. For PCPs, I think you still need to go in, right? Like, you still should go in and get your checkup, talk to your docs when something's going on. I think that's totally fine. If it's something that is systemic, right? If you want to ask them and you're like, hey, my shoulder hurts, what should I do? They're going to refer you to PT, and that's totally fine. I don't have any issue with that. I think that's a great start. I would actually rather them do that instead of trying to figure out what is going on, giving them a medication that doesn't actually fix the problem, but is just like a band-aid solution, and then refer them back to us anyways. And then we got to sift through all that, right? So essentially, it is just creating better patient expectations before they even step foot in our door. I think that's probably the biggest thing when it comes to like what PCPs may think. I honestly like value what they do and how they refer, or at least from what I've seen from the PCPs that I do get referrals from. I think that they do a great job in that sense. Now, the orthos, for sure, pain and spine, and neurosurge, I think those people actually benefit the most from us because we are streamlining their jobs. Like, we are taking like a majority of their patients and saying, hey, we could fix this. Boom, done. Right. And then the others, listen, I can't fix this without your help. So let's see what we can do together. I think that is very, very powerful for us to actually collaborate together instead of just working in our own independent like niches. I think that this is way, way, way more helpful because then we're like, hey, we tried this and it's not working. Conservative care has been exhausted. Let's see what your thoughts are and what you'd like to proceed with next. I think that's totally fine, right? I think the big one, the people that are going to have the biggest issue is going to be sports med. And that is because we do a pretty fantastic job. If you are a skilled PT, you are going to do a really, really thorough job of evaluating your patients and not giving a nondescript diagnosis and then injecting or giving medication and hoping for the best, right? And then referring them to PT anyways. I think that is a huge thing that we can absolutely cut down unnecessary costs on, as well as improve efficiency within our system. I think that for a lot of this, if we talk about the increased responsibilities that we mentioned previously, let's be real. How many of the patients that we're seeing are being prescribed virtually all the same stuff? Like, it's usually going to be gabapentin for nerve pain. It's going to be a prednisone or medrol dose pack to reduce like inflammation if they think that's something that is usually spine related, or maybe they're given like a meloxicam or any other NSAID to help deal with an inflammatory response. Right? I think that PTs are certainly like able to understand when and how to utilize these medications. It's very limited. I'm not asking for everything, right? I'm only asking for the main medications that we see prescribed across the board, right?
And like we talked about earlier, like this stuff is already being like, it's like a blanket prescription. You come with pain, you're getting hit with here's your pain cocktail, right? You get a stronger NSAID, right? You get maybe a prednisone if it's really lit up. If it's radicular type pain, you get hit with a gabapentin, right? So we already know there's not much of a thought process. There's not much of a there can't be much critical thinking when it comes to this. And from what we've seen, like there's a like regardless of what other conditions you have, your age, whatever it is, like these things are being prescribed. So like, we do believe like PTs would certainly be capable of. Again, we're not asking for much. Limited prescription rights. PTs would certainly be able to assume this role because, like as we see, like there's not much of a thought process going on with the prescription. I think we would even maybe be able to do an even better job of prescribing these appropriately.
Yeah, and listen. I like I said, like me and Mark said, we are asking for the basic medications. We're not even talking about injections, which I think that my standpoint is a little bit more toned down by not including that, because I do think that is an aspect that can also be utilized more conservatively and more judiciously for some of our patients, where it's like, I'm not asking them to give an epidural, but for certain other injections, it's like, hey, let's hold off. Let's see what we can do first. And then after that, we can trial that. And I think with the anatomical knowledge that we already have, I think that having the skills to perform an injection is not very far off. It's not rocket science to be able to do that. So I'm not saying that that's what I am advocating for, but I think that is certainly something that we could be capable of within, if our scope is to be expanded, right? But I think let's start off with the basics. Let's make sure that our anyone who can do any of these additional privileges are more than qualified to do so. I want to make sure that if this is something that goes through, that the people who are doing it are doing a spectacular job, especially if this is what we're advocating for, which is the advancement of the field, right? So I think that with all that being said, medication, imaging, all these things are already being overly utilized. Just like what Mark said, everyone's getting it, right? And PTs are already trained to be more conservative in their care. Like, this applies to all of the above. We are more conservative when it applies to recommending medication, imaging, surgery, referrals, any of these things. We try to manage patients conservatively as best as we can until it's like, hey, this doesn't seem right. Well, we're going to ship them. And I tell my patients, hey, I'm not the biggest advocate for these things, but if it's something I think you need, I will be the first person to tell you, please leave. You need a consult with someone else. And then I make that referral. I think that is such a great way to earn your patients' trust, because they're like, oh, wow, he doesn't just want to like kick me out the door and without even taking a look at me. He doesn't want to just like make a quick buck off of me or just give me some sort of medication just so that I leave, right? I think that this is so powerful, right? So with all that being said, that kind of leads to like pretty much what Mark talked about previously, our solution for this, which is making sure that our PTs that are doing this are being certified, that they're being trained to prevent overutilization, to prevent any mismanagement of these patients, so that they understand how these patients should be triaged and referred, all these things, right? Also, referrals are still going to happen the same way that we do them. They're just going to be faster. Maybe we could have a little bit more priority when it comes to us making that recommendation or making that referral versus the patient scheduling themselves. I think that would be awesome to know that what we are saying as medical professionals is being heard and prioritized. Now, the other thing is we're also not necessarily changing our role per se. We're just now becoming the primary provider, the first contact point. I think that a lot of professions would probably agree that PTs do a decent job when it comes to red flag screening, as well as just making sure, is this something that we can treat, and then being able to delegate care in that manner. Also, it's just that when we do this, we follow the organic chain of command when it comes to utilizing conservative treatment methods into less conservative treatment methods, such as pharmaceutical interventions, injections, or surgery, right? And then we also just streamline that process. I think that that is very, very helpful for patients, as well as for these other medical providers as well. And on top of that, we're also, like we said before, we are creating more resources for these people. We are cutting down on costs. We are helping free up more valuable real estate in their schedules. I guarantee you, surgeons are so much happier when they see true surgical candidates that they can help, that they can actually book and then perform surgery. Same thing for other physicians who are going to perform whatever procedure that they're going to perform, instead of them just being like, okay, I saw you, go see PT. It just doesn't make sense. Cut out that step. It's not necessary.
Yeah. Now, a lot of what we talked about there is essentially making the healthcare system more efficient by streamlining the process. Right now, I think at least in the United States, healthcare is run as a business. There are, profit needs to be made. People got to get paid. Money has to be generated, right? So I think the most common counter argument to this would be, hey, we see that if PTs are going to be the first contact provider, imaging is going to be utilized less, medications are going to be utilized less, perhaps certain referrals are going to be less utilized. That may result in less visits, or at least less physician visits, which their codes may be reimbursed more. And we're going to have to answer for that, right? So the counter argument from our standpoint would be that, hey, like Kane said, you're going to create more resources. Maybe the visits actually don't go down for those providers that that maybe wouldn't get referred to as much. Maybe they stay the same, or maybe they go up because they have more resources available to utilize that, right? So that, at least in the United States, we need to be able to answer for that question. Now, if, let's say, imaging utilization does decrease, medication prescription does decrease, are we able, from the insurance standpoint, be able to say, hey, us as PTs, we are saving you money on imaging, we're saving you money on medication. Could we negotiate a higher reimbursement rate for PTs, right? I mean, we've seen that happen just from what PTs are doing right now in terms of, reducing surgery, stuff like that. But if we have this proposed expanded scope, are we able to do so with decreasing imaging and medication use? I don't know. And if we are able to negotiate a higher compensation for PT codes, is that enough to offset the supposed decreased revenue from imaging and medication? I'm not sure. I'm not sure if we have even any kind of data in that regard. I mean, what we do know is that the patient experience would be better. People would be taking less medication, less imaging, less exposure to radiation, just less unnecessary services. We're saving time for the patient. We're making the system more efficient. But again, healthcare is a business. We understand that. We operate within that system, and it's still yet to be seen if it would be feasible within hospital networks to make the system more efficient, right? I said we're affecting money, profit, stuff like that, so we have to keep that in mind. We understand that. We're realistic. The purpose of today's episode was to say, hey, who want to expand the field of PT? What should we be able to do? And how will we get there with, what avenue? How do we start to expand the field? How do we start to make the argument for doing so? And but also being realistic about it. Okay, Kane. anything else to add to today's episode?
Man, I just realized that we could do another full episode on improving reimbursement for PTs and how exactly we could navigate that topic, right? I think that would be huge. Oh man, it's going on there. That's for sure. But other than that, no, that we covered a whole ton when it comes to this proposed expanded scope. I think that this would be great to spark discussion with and just see how receptive people are towards it, and then just seeing like potential pitfalls in our proposed plan, and then seeing where it could go on from there. That I just want to be able to spark discussion to see where we can continue moving forward.
Mm-hmm. So, quick summary then, like we talked about, PT autonomy has certainly expanded. I think direct access has a lot to do with that. But how can we expand further? I think Kane and I both agree that additional privileges, such as the main three we talked about today, being able to order imaging, place referrals, and have some limited medication prescription, I think are all realistic expectations that we can have as PTs going forward. The main concept that we're looking to facilitate these additional privileges through is us being the first PTs, us being the first contact for people with orthopedic pain. We have the knowledge, we have the skill set, we have the time and availability to be able to triage patients. Will we treat them? Do they need to be referred? Do they need imaging? Do they need medication? Again, we get some knowledge in school. We know how to screen for red flags. We understand some imaging. We understand some medication. That's not to be said if we're going to be first contact providers. We do believe that some additional knowledge or some additional information is needed, especially regarding the medication aspect, especially regarding the appropriateness of referring for certain imaging aspect. If we want to begin to expand and get these privileges, I think we need to start with a certain amount of people who utilize these services appropriately, gather data, and start to present that data so that we can start to implement it on a larger scale. When it comes to implementing on a larger scale, I think getting that kind of information into school so newer PTs have a more direct path to being first contact providers is appropriate. We also talked about the possibility of perhaps a certification exam, course, competencies, things like that. But I think first we need the smaller scale data to start to build our case for being first contact providers. Lastly, we talked about, other scopes of practice, other providers, ortho, sports med, spine and pain. We're not looking to take away from these providers. We just think expanding the field of PT with some of the responsibilities that we discussed earlier will actually open up these other providers to see more appropriate patients, and we can offload them so they have more resources to even expand on their own practices. Okay, so we want to emphasize that with expanding the field of PT, we're not looking to overtake, we're not looking to take away from other providers. Rather, we are looking to expand our own field, get some more autonomy, more responsibility, make the patient experience improved, more efficient, and work with other providers together to achieve that ultimate goal of a better patient experience. Well, that wraps up another episode of the PT Good Podcast, the #1 motivational and educational ortho PT podcast. Subscribe to us on whatever platform you're listening to us on, YouTube, Spotify, or Apple Podcasts. Don't forget to share this with others who would benefit. Thanks for listening. We hope you enjoyed, and we'll see you on the next episode.
Miss you, love you, bye.